So we are interested about what kind of claims can be found on the market in the food supply, and also on what kind of foods those claims can be found. Obviously, when doing research work related with the food supply, first you need to be aware what are you investigating. Therefore, we first decided to do taxonomy on food labeling information and data. So to know what is of our interest, we divided it into information and into claims. For when we are talking about information, as you know, we can talk about mandatory food information and other information. However, when you talk about claims, you can talk about worded or symbolic or claims in picture. And claims were further divided into nutrition claims or symbols, into health claims or symbol, or other claims and symbols. Of course, we did quite a more in-depth taxonomy for specifically for health claims and symbols. And I should also mention that we did a taxonomy related with the context factors. As mentioned before, the context could have a major contribution into major effect in consumer behavior. So this was also our topic. Just to get a bit more into details into taxonomy related with health claims, we divided it into the content, effect direction. Let's say when you're having claims on foods, you can talk about maintenance of something, about increase, reduction, effect certainty, whether there's a qualifier included into the claim, it helps, it contributes, it has a role, and so on. Then framing can be either positive or negative. As you know, mostly we have positive framing in Europe. Claims can be targeting either the general population or specific target groups. So we're interested into that target group. Regarding the scientific agreement in Europe, we only have option to make claims which are scientifically agreed in a sufficient way. However, as you know, in some countries, other options are also possible. That's why we also included this into our taxonomy. From the start, we knew quite, we were quite, how to say, we expected that the taxonomy which we used in work package 1 was not the same as could be understood by consumers. So our idea was that from later work done in further work packages, we revised this taxonomy from the point of view of consumers, so how consumers interpret health claims. But as you will hear later on by Professor, in a speech by Professor Etz, it's quite a challenge because we determined that consumers are having difficulties distinguishing even some differences which were major in our expert taxonomy. So we weren't able to go in a very into much of details in the consumer related taxonomy. So if I go into the results related to the prevalence on nutrition and health related claims on prepackaged foods, I should first tell you that how the study was done. We prepared a large data set of foods which were collected in 5 countries. We selected United Kingdom, Netherlands, Germany, Spain, and Slovenia. In each country, we visited 3 different stores one large supermarket, one discounter, and one neighborhood store. And based on the randomization protocol, we selected 400 foods, about 400 foods per country in those stores. We purchased the foods, and in the lab we did data extraction and later on the assessment of the data on the which was found on the food packaging. Going into results, you can see that in average, so these are data for all 5 countries together, nutrition claims were found on 21% of the foods which were included to our sample. I must say that we selected all pre-packed foods with the exclusion of food supplements and some minor food categories. So this is more or less all food supply related to pre-packed foods. Within the nutrition claims, most commonly we found that these were nutrient content claims. These were found on 20% of the products. However, nutrient comparative claims were quite less common. Health claims were found on 11% of the investigated foods, mostly as either general health claims, these were found on 7%, or as so-called function claims, which were found on 5% of the products. Maybe not surprisingly, but it's a fact that reduction of disease risk claims and children's development and health claims were found on a very few products, less than 1% of the products in our data sample. When doing the study, we also determined that on food labels, there are some claims which legally could not be categorized as either nutrition or health claims, but in our opinion, those were claims which were somehow related to health. For example, one of your 5 a day contains only brown sugar, and such claims. So these were neither nutrition or health claims. So we invented another category, which we called health-related ingredient claims. Such claims were found on about 4% of the products. Going a bit more into details into different countries, I can say that we say that we observed quite a major differences between different countries regarding the use of nutrition claims and health claims and also symbols. In previous slide, I didn't have data. No, in this slide, I have data about the proportion of symbolic claims on the foods. We found out that the country with most commonly used symbolic claims was the Netherlands, and that's why the proportion of health claims in general altogether was also quite high in the Netherlands. The highest proportion of nutrition claims was found in the UK. So, but as you can see, the proportion of products with health claims is somewhere between 7 and 14%. Considering that our study was done in a way that we went into the stores, we sampled 400 products per country, which is not a major number. It was interesting to compare this data with a study which was done in a different way. In Slovenia, we done a study in which we collected data on all products which were found in a market. We had 5,000 and over 5,000 of products in our database, and from the figure below, you can see that in the Slovenian study, the proportion of foods labeled with health claims was 13%. So on the sample of 5,000 products, the proportion was 13%. However, in CLYMBOL study, the proportion was 12.5%. This obviously means that, the protocol used in the CLYMBOL also allowed us to do estimation of these figures with quite less money and hours than in comparison that we would go into stores and collect all foods available in those countries, in the selected stores. It's also interesting to see the data, how commonly nutrition and health claims and symbols are found on foods in different food categories. We can see that the food category with highest prevalence of both nutrition and health claims are baby foods. I must say that these were not claims which would need to be on those foods by some mandatory conditions. So we did not, let's say, count the fact that the food contains calcium in the nutrition labeling, in a nutrition declaration as a nutrition claims, because these are mandatory in this food category. So considering this, the fact that this category is quite different shows that obviously producers are using this kind of claims because they are possible, because they think they would be of interest to the users and so on. Looking to the other food categories, we can say that nutrition claims are present on more or less all food categories, and health claims are somehow chasing nutrition claims more or less. Going deeper into what kind of claims are there on the market, we're of course also interested into specific claims and nutrients which are most commonly mentioned on the labelings, because this was also very interesting for further work in the CLYMBOL project. The reason why we were doing all this was also to enable us to decide to which claims we should focus in the further studies. So the nutrient which was most commonly mentioned in the both nutrition and health claims were vitamins and minerals, which were found on 16%, which were present in 16% of all health claims, mostly as any vitamin, these were on 10%, or any mineral, this was on 6%, and the most common vitamin was vitamin C, which was found on 2% of the products, and calcium found on 3% of the products. Typical example of vitamin C was the extra C supports your natural resistance. And we also found claims which were not directly related to a specific vitamin, but was like contains 8 vitamins that are needed for normal growth and development of children. And typical claims for minerals was contains microelements needed for functioning of the body, or for specific nutrient it was calcium for growing strong bones. Other nutrients which were mentioned in the claims and quite commonly were fat, specifically either total fat, saturated fat, unsaturated fat, or omega-3s, followed by energy, protein, carbohydrates, specifically sugar, and so on. We also did investigation which health outcomes are covered by the health claims, and I think that Mike will go a bit deeper into this subject, so I will not go into details here. I would just like to mention that we can conclude that between 20 and 35% of the prepacked products found on the market in those 5 countries has been found to carry claims. That health logos were reported in all countries, the highest prevalence in the Dutch sample, and that nutrition claims accounted for the majority of health-related information on food products. Concerning context factors, I can say that the most popular symbol used across 5 countries was green dot, which is a symbol that showed that the manufacturer has paid a fee for the recycling. And the second most popular health non-related symbol was tidy man. Overall, in 5 countries, the type of images that most often appeared on products were either food itself or some constituent of the food. The last slide is about the regulatory issues related with the claims. We are, of course, also interested we were wondering whether the claims, either nutrition or health claims, are used in a way that is provided in the regulation. We found that nutrition claims are used on products which are also labeling nutrition declaration in almost all cases, in 96% of the cases. And conditions for having those claims on the food labeling were met in 75% of the cases. For 7% of the cases, we can say, considering the labeling data, that conditions were not met. However, for the rest, we would need to do a chemical analysis to be sure. For health claims, nutrition declaration was found on 97% of the foods labeled with a specific health claim. We found healthy lifestyle statement on about 70% of the foods labeled with claims, and the required pattern on consumption on 81% of the claims. However, only 19% of the products labeled with a health-related trademark, brand name, or fancy name was also labeled with a specific health claim, but 78% of those were labeled with a specific nutrition claim. And only 33% of the products were labeled, of the products which were labeled by a general health claim were also labeled by a specific health claims, and 70% of those were labeled, were carrying a nutrition claim. I should say that the majority of the results presented here were published very recently in a paper in Nutrients. It's freely accessible online, so you can easily download it and go even further into details. And now I think I can invite Mike to present the other part of the work.
So following on from Igor's presentation, my task is to do or present some further analyses of this database of foods and their packaging that we collected in 5 different countries: Netherlands, Slovenia, Spain, Germany, and the UK. And Igor's described the methods for compiling this database. The questions that I'd like to address in my presentation are what is the nutritional quality of the foods carrying health-related claims? And to begin to talk about, do health and nutrition claims meet consumer health needs? Though I know Monique and others are going to talking about that later. Next. So I'll just go back to this one. The reason why we wanted to look at the nutritional quality of foods carrying health-related claims, because it is said in some quarters that foods with claims are not healthier or not any healthier than foods without claims, and we really wanted to produce empirical findings to test that hypothesis. By nutritional quality, we investigated that in two ways. One, just looking at the mean levels of different nutrients in the foods with and without claims. And secondly, using just one particular nutrient profiling model. Nutrient profiling models are designed to score or classify foods according to their healthiness. And of course, there's no gold standard way of classifying foods for their healthiness or scoring them. So we used a nutrient profiling model devised by the Australian government for regulating claims. And what we looked at, secondly, was whether different nutrient profiling models would classify foods in different ways. We used some claim regulatory models, the Australian model I just suggested, the US Food and Drug Administration model for regulating claims, and a nutrient profiling model proposed by the European Commission in 1990. And again, we also looked at whether symbols, such as the ones we found in our survey and by CLYMBOL participating countries, the Nordic keyhole, the Finnish heart symbol, and the Choices International logo, how they classify foods in our database. And indeed, we could look at how they could be used for regulating health claims. And finally, we looked at the public health relevance of some of these claims to see how they, whether the numbers or the prevalence related in any way to public health need. So some results. I'll move on to the results. So this first table of results shows you the difference in the nutritional quality of foods carrying health-related claims, both nutrition claims and health claims. And you'll remember here the hypothesis was that foods with health claims were no more or less healthy than foods without health claims. And this slide shows you that that hypothesis is overturned, refuted, disproved. Clearly the foods here, both the health claims and the nutrition claims, have slightly lower energy, slightly less total sugars, slightly lower saturated fat, slightly more fiber, and slightly lower in sodium. You see the statistically significant findings in red, and where there was a difference, actually more than 25% difference between the foods with the claims and the foods without health claims are highlighted with little arrows. So you see that there were quite some differences. The question is, fundamentally, whether these differences are small or big. I mean, the numbers in some cases, like the difference in total sugars, is only 3 grams of sugar per 100 grams difference. Is that a big number or a small number? And I'll come on to that later. Another way of looking at it, as I said, was to look at the healthiness of the foods carrying the claims with or without carrying foods with or without carrying the claims. So here we've looked at how the foods in the database were classified according to the Australia and New Zealand's nutrient profiling model. In this model is a relatively weak model. It only, in all foods in our database, 43% of the foods were classified as healthier by the model. So it's not picking out the very most healthiest foods, it's picking out the sort of average healthiest sort of foods. But foods, 70% of foods that carried health claims in this instance were classified as healthier by the model, and slightly fewer, 61% of nutrition claims were classified by the model. So again, we're showing that foods that are carrying the claims are slightly healthier than, than the foods without health claims. Now, you can say 70% is quite a good figure, but remember 43% of foods, all foods, that whether they carry a health claim or not, are classified as healthier by the model, and 30% of the foods that are actually carrying health claims in this database wouldn't be allowed to do so if they were found in Australia and New Zealand, because they would fail the Australia and New Zealand nutrient profiling model, which I think argues that we probably, though this is a conclusion that maybe I shouldn't be making at this point, that we need a nutrient profiling model in Europe. Also, whether this slide looks at whether having a nutrient profiling model would actually make a difference to the healthiness of the foods carrying claims or not carrying claims. You'll remember that foods carrying claims are already a little bit healthier than foods without claims. But if we had a nutrient profiling model, that difference would become even greater. And this shows what would happen, if you like, to the foods if we only allowed foods carrying health claims to pass the Australia-New Zealand nutrient profiling model. If you look at the total sugars in this case again, as I said before, foods carrying health claims are 3 grams lower in sugar than foods without health claims. But if we had a nutrient profiling model, that would increase to a number of 7 grams. So it would improve the healthiness of the foods in Europe if we had a model similar to the Australia-New Zealand nutrient profiling model. So that's the end of that bit of our analysis, except to say that we are still doing some work to explore whether these differences are big or small. 3.1 grams sounds a low number for the total sugar difference, but on the other hand, there's only around 14 grams on average of sugar per food, per 100 gram per food. So this is quite a big, or 25% reduction, roughly, in terms of the sugar content. Would that make a significant health difference if we started to reduce the sugar content of foods in the diet by 25%? This, of course, is predicated on the basis that consumers actually react to these health claims and change their diets accordingly. But the next stage of our analysis is to do some modeling to see whether these differences that we find between foods with and without health claims would make a significant difference to consumer health if they were to act on the claims. So wait for that paper, and it should come out in a year's or so's time. But it is the million-dollar question. You know, are these foods, even though they look a bit healthier, really significantly healthier in terms of public health? Right, now to look at the well-known controversy about nutrient profiling models. I said we used the Australian-New Zealand model to test, to look at how many foods in the database with and without claims would pass the model. And here is just a slide looking at 3 different models, as I said. The Australian-New Zealand model in blue, the American nutrient profiling model embedded in their legislation for regulating health claims in red, and the latest version, the 1990 version of the European Commission's proposed model. You can see all these models roughly do the same thing. They're all classifying foods and drinks which are higher in fat or sugar. These foods are categorized by a food categorization, quite a simple food categorization system, which is the basis of the UK Eat Well guide. And all models generally classify 10 or 20% of foods, only 10 or 20% of foods high in fat or sugar pass any of these 3 models, where on contrast, for example, most of the fruit and vegetables pass the model in all 3 cases. And similarly with the starchy carbohydrates, most of the foods, around 70 or 65%, pass the foods of all 3 models. But there are some differences between them, notably here, where for example, with the composite foods, the American model is much tougher than the other two models. So here, all we are looking at here really is the difference between models, and to say that these 3 models, at least, do appear to be doing roughly the same sort of job. And to some degree, I now regret that we just didn't go with one of these models like the EU model or even the Australian-New Zealand model, because then we would at least have a model in Europe. Just to look at the nutrient profiling models underpinning the symbols that we looked at in CLYMBOL, the choices symbol, the Finnish heart symbol, and the keyhole symbol. This is on the same axis as the previous slide. So you can see all these three models are really much stricter than the regulatory models. They're picking out, in a way, the healthiest foods on the market. And actually, from this analysis, it looks like they differ by category, but in general, I think you can sort of see that the keyhole is slightly stricter than the choices or the Finnish heart symbol, but it's much of a muchness, really. In a way, I think they're doing roughly the same sorts of jobs too, but in this case, they're picking out the healthiest foods on the market. We could go more into that, but I think that's enough on that part of the project. So finally, this issue of need. I think one of the things that CLYMBOL has looked at is, to some degree at least, is whether health claims are effective or not. And by effective, we mean, I think, you'll see or hear from different presentations different things. Sometimes we're talking about helping consumers understand the food more, sometimes in relationship to their health. Sometimes by effective we mean selling the product so that people buy more of it. And in my terms, I think what I would like to see is health claims actually helping consumers get healthier. And by getting healthier, I think we mean dying at a greater age, and also having healthier years of life, more healthier years of life. So in this analysis, we looked at the prevalence of the claims, which Igor showed you, against what we know about the health burden from the global burden of disease analysis. So from the global burden of disease analysis, that we know in the EU that about 12% of the DALYs lost, that's the years of life lost prematurely and years of life lost in disability, about 12.5% of those years of life lost across the whole of the EU are because of overnutrition in some sense or other. And a big percentage of that, the top percentage of that, is because of diets high in sodium. Relatively few down here, for example, are due to suboptimal levels in calcium or even low in milk. So here is the global burden of disease analysis, looking at the burden of disease in this case in terms of DALYs for both overnutrition and undernutrition. And here on the right is a list of claims that you've seen already, which lists the nutrition claims, in this case, just the nutrition claims, in terms of what they're talking about. Igor said that most of the nutrition claims, 35%, in fact, are related to vitamin and minerals. But actually, the global burden of disease suggests that this is a comparatively small in relationship to the burden of disease. Only 1% of the burden of disease is due to vitamin and mineral deficiencies compared with overnutrition, which is at 12%. So in Europe, undernutrition, relatively small. Most of the nutrition claims are related to vitamins and minerals. And similarly, as I said earlier, the high in sodium is a big cause of the burden of diet-related DALYs lost in Europe, but it's a relatively low sort of claim. So I think this analysis demonstrates fairly convincingly that the nutrition claims are not really addressing people's actual needs. They're addressing people's perceived needs, perhaps. And doing the same thing with health claims, Igor showed you that the biggest burden, the type of health claim that has the highest prevalence are related to functions of the digestive system, and those gut claims you hear all the time in the adverts and see on the packets. But digestive diseases are a relatively small burden of cause of the DALYs lost in Europe, only 1.7%. Whereas things like cardiovascular disease, which is that I should declare an interest here since I'm funded by the British Heart Foundation, it causes 18% of all DALYs lost in Europe, but it's a relatively rare there are relatively few claims, health claims out there related to the functions of the cardiovascular system. So the conclusion from this I draw is that health claims aren't doing health and nutrition claims aren't doing a very good job when it's actually, if they're trying to promote people's health in Europe. And I think that's all I've got to say. Oh, just the findings and the next steps for this bit of the analysis. Marginal differences in nutritional quality, as I've said, well, I shouldn't say marginal differences, difficult to quantify differences. Using a nutrient profile model like the Australian, New Zealand nutrient profile model would improve the nutritional quality, undoubtedly. The strictness of the different models varies by model and indeed by food category. Claims have little public health relevance, and the really next step is what we need to do is to model the impact of the claims on health outcomes using UK mortality data and a disease risk model, and also hopefully some of the results that you'll be hearing later today in relationship to the effect of claims on consumer purchases and consumption. Thank you.